Hello, I'm Dr. Karen Waller. I'm a PhD candidate at the University of Sydney School of Public Health, and today I'll be presenting a study looking at vaccine-preventable infections among solid organ transplant recipients in a data-linked cohort study from New South Wales, Australia, 2000 to 2015. Solid organ transplantation is a rare therapy in medicine in that it not only saves lives, but improves quality of life. And where there is an alternative, namely dialysis for kidney failure patients, transplantation has been shown to be cost-effective by comparison. Now, after receiving an organ transplantation, recipients do require lifelong immunosuppression in order to not reject the transplanted organ. As such, recipients are both likely to have infections more commonly and more severely than the general population, and we know they are a major source of both morbidity and mortality among transplant recipients. Infections are listed as the third most common cause of death for organ recipients, with around 15% of transplant recipients reported to die from infections. Now, some infections are preventable with vaccination. Challenges include both effective uptake of vaccination, as well as the effectiveness of vaccinations in an immunosuppressed cohort. We know that rates of infection vary depending on the prevalence of the disease among the baseline population, as well as underlying immunosuppression among recipients, as well as, of course, the uptake of vaccinations. So how big of a problem are vaccine-preventable infections in transplant recipients? In this study, we were aiming to understand the burden of these infections among solid organ recipients in Australia. This data is not usually known, as transplant recipients are not followed for these specific indications. We used the SAFE-BOD Data Linkage study, which is a study based out of New South Wales, Australia. New South Wales is the most populous state in Australia and is demographically representative of the country. We looked at all solid organ transplant recipients in New South Wales who received an organ between the year 2000 to 2015. And we linked this study population from their transplant registries to routinely collected administrative data, namely hospital admissions data, notifiable infections databases, as well as the death register. Using this information, we were able to identify vaccine-preventable infections occurring after transplantation, as listed here. We were able to calculate the crude incidence of infection in this population, as well as standardised incident ratios compared to the general Australian population, which was standardised according to gender, age, as well as calendar year. We also identified associated hospitalisations and deaths that were associated with these vaccine-preventable infections. In total, with this cohort, there were nearly 5,000 solid organ recipients who were followed for nearly 40,000 person years of follow-up. Among the vaccine-preventable infections in the notifiable diseases database, there were 4 infections which occurred in this cohort. By far the most common was influenza, with over 500 influenza notifications and a crude incidence of over 1,000 per 100,000 person years. Pertussis and pneumococcal both had a number of cases, and there was a single case of mumps. For both influenza and pneumococcal, hospitalisation rates were nearly 50% among infection cases in this population, although deaths were uncommon. When calculating the standardised incidence ratios, we found that both pneumococcal and influenza occurred far more commonly in this population than in the general population, with incidence ratios nearly 10 times that of the general population. Mumps and pertussis did not occur statistically more commonly than the general population. Looking at this excess burden over time, we could see a clear trend with influenza that the excess burden of influenza has decreased over time, with a standardised incidence ratio of nearly 50 at the beginning of this cohort, which had decreased to under 10 times the rate of infections by the end of the cohort period. For pertussis, there was also a reduction in the standardised incidence ratio, with initially an excess burden, which reduced down to the general population rate by the end of the cohort. The trend was less clear for the excess burden of pneumococcal, which remained elevated over time. We also broke down the rates of infection by different organ types. The green line here represents lung transplant recipients. And this demonstrates that by the end of 10 years post-transplant, nearly 3 in 10 lung transplant recipients were affected by a vaccine-preventable infection. This is perhaps not surprising given that the most common vaccine-preventable infections in this cohort were respiratory in nature. Among other transplant recipients, around 1 in 10 would be affected by a vaccine-preventable infection at the end of 10 years. In summary, in this cohort study, we were able to identify, with the use of data linkage, information that gives great insights into the ongoing care of transplant recipients. Firstly, we found that there are still very high rates of influenza and invasive pneumococcal disease in transplant recipients compared to the general population, and that these two infections were associated with very high hospitalisation rates. This suggests there is a significant need to keep targeting these infections and vaccinations for them among transplant recipients. It was interesting to see there was a decrease in the excess burden of influenza over time. And we wonder whether this may be due to improved vaccination strategies for this infection, as there has certainly been significant work amongst this in the transplant infectious diseases community. We also note that lung transplant recipients were disproportionately affected by these vaccine-preventable infections, suggesting that they are a key target of vaccinations going forward. And indeed, this work suggests further work can be done to determine whether excess burden of infection can be reduced with patients receiving vaccinations as recommended, or also seeing whether our vaccination strategies are ineffective. It may be that transplant recipients require dose-escalated vaccinations, as we know organ failure patients do for the hepatitis B vaccination, for instance. We hope this work will be useful and can help reduce the incidence and morbidity associated with these infections among transplant recipients in the future. Thank you.